Sollis. Better insights for better outcomes. This session was recorded live at our Advances in Population Health Management workshop in London, November 2018.
It gives me great pleasure now to invite Mr. Satnam Baines to the stage. Satnam is the founder and CEO of a company called Health Fabric. His main interest lies in technology. How can technology enable behavioural and cultural transformation? So we talked a little bit earlier about the need to move the narrative to a health and well-being agenda. Satnam and his great company are at the heart of that revolution, and Sollis and Satnam are currently talking about how do we capture some of the great data that he's collecting through his app into our population health platform. Satnam.
So Nigel, thank you for that very generous introduction. It's taken me 3.5 hours to get here from Birmingham, as you probably noticed from my accent, so I'll try and do my best actually, but I'm a little bit spent. So anyway, in terms of Health Fabric, I want to talk about the thing that I really enjoy, which is all about self-management. Those who haven't heard about Health Fabric before, Health Fabric is a digital platform all about self-management to help people to self-manage their long-term conditions. And we've been doing this for quite a while, for a number of years now. And a lot of the work that we've done, actually, I'm the recipient, so I'm the learner here in terms of the co-creation between patients, GPs and patient advocacy groups. So a lot of the work that we've done actually is through working with those organisations, which has been great. So in terms of what we do, we're really focused on two groups of stakeholders. So the stakeholders, the obvious stakeholders, the terminology sometimes throws me, is citizens, is people, it's not patients, it's actually people who perhaps want to get more involved in their wellness, or they want to manage a number of long-term conditions or one long-term condition. So that's one broad group of stakeholders. And the other group of stakeholders that we have are the people who will support them in around that. So that could be GPs, it could be patient advocacy groups. I do a lot of work with GP federations. So again, it's and from their perspective, I think over the years we've evolved, and what we give the capability to some of these organisations to create self-help plans, but branded to their organisation. So as a GP federation might come together, they might brand themselves in a certain way and start bidding for pieces of transformation work within the community. And what they're really keen on is to sort of identify themselves as an entity within their locality. So we help them to do that. So that's really key in terms of some of the things that we try and do. And this is why the work with Sollis is so important, because Sollis helps us engage with both of those stakeholders. So there's a life cycle associated with this. One of the things that, initially the work with Sollis is all about understanding who needs the help in the first place. To identify those. And I'm fascinated when I work with Nigel and his team, because of the fact that they go into locality, they find out, well, actually, this is the makeup of the population, this is the level of comorbidity, this is how much it costs. So all of that is really valuable information for us, and what we then do is take that information and turn that into a set of self-help programs, so where patients can sort of take on board the health application and then do whatever they need to do in around that. So this is a cycle, and it's really important because of the fact that we're getting all the clinical intelligence, the risk stratification, all that information, but what we're also getting is the patient-generated data. And then combining those two data sets is something that hasn't really been done properly in the country, I would say. So I'm quite excited about working with Sollis to enable some of that. And the other thing is that we can feed that back in as a cycle to understand how to do it better the next time around. So, again, I think the majority of this presentation I want to share our learning with you in terms of what we've learned. But one of the things that I would perhaps recommend is that you look at some of the content that's already out there from the Health Foundation. And the Health Foundation themselves, they've created some really, they've got a report here about supporting self-management, and they talk about 3 or 4 aspects and around that. And they talk about making it easy, making it attractive, making it social and timely. So we take a lot of that information. Then what we do, we apply it within the given situation for that cohort. So, you know, I would say those are the patterns of engagement with the population. But what we really need to do is to take that and localize it to any implementation, depending upon what we're trying to do. And there's another recent report at the Health Foundation, which is really quite interesting because it defines a business case of doing this in the first place. And within that, you know, they come out with some figures about 38% of the population. There's a 38% reduction in emergency admissions, 32% fewer attendances into A&E, and 18% fewer general practice appointments. So, you know, when we're doing this piece of work, we have to quantify it, we have to justify it, and there's a couple of mechanisms that we adopt in terms of how to do that in the first place. So getting back into the learning of it, like what works? Like if we go into any locality, what is it that's common across all of these localities or GP practices? And this, I would say there's three kind of areas to focus on in terms of self-management. The first is turning data into information. So, you know, like I spent a lot of time integrating into EMIS and TPP, and I thought, well, you know, that's going to sort of solve all the world's problems in terms of patients, but it gave me a lot of problems integrating it in the first place. But the actual information had to be presented back to the patient in a way that they would understand that. And it also had to be linked in perhaps with contextual information that was local or national, like NHS choices. But the key thing here is to make the information relevant to the individual and digestible in the way that they can understand it. I've also worked with different ethnic groups, and the way that they understand, and the culture side of things comes into this in a big way as well. See, the other aspect of it is to make it fun and social. So it's easier said than done. Like, how do you make diabetes management fun and social? So, but what we find is that actually, you know, like people carry these problems for a number of years, and one of the things that they do like to do is to share those issues with other people and perhaps go into groups and work in that context. And the third aim is about support and community, and this is really, really important. And you know, in terms of support, there's a number of ways you could do this. Like you could sort of say, well, I'll get some one-to-one coaching, which always works, but that's quite heavy on resource utilisation with healthcare professionals within GP practices. What the GPs that we work with are doing, they're federating and creating these long-term condition hubs, and they're creating support networks of people with long-term conditions and getting them in to have discussions about their long-term conditions in that way. Or they can go online, you know, to the various forums which are trusted. But the three things I'd like you to take away in around that, what we're actually talking about in this area is personalisation, so that's all to do with the data side of things. We're talking about engagement, which is the aspect to make it fun and social. And the third bit is the support side of things. So those are the secret sauce recipe of self-management. And also the other thing that we have to bear in mind is the patient journey. So let's take an individual patient and take them through what their individual, like their mindset when we try and do some of these things. Now what happens is that first you have to get the individual at the right time to get them engaged. Like, so it might be that they've told you've just let them know they've had hypertension, and suddenly they get really activated based upon that. Or you work with their family members and they perhaps but you have to get them on board, really. So there's a process of them understanding what they need to do and accepting it. So that's the first two key stages of self-management. And then it's the actual doing, like what is it I'm going to change about myself, and how am I going to measure that? What are the goals associated with it? And what kind of support am I going to get it around that? And then it's reviewing that information, and then perhaps going around the circle again, trying to understand it in a different way. So, and then I think like the other thing is that some of my team get involved in personalised care planning, and there's certain cases that stick in my head. When we're talking about all of this, health, without a doubt, in self-management is more social than anything else. Like, it's about your social circumstances. So about a year ago, one of our key members of staff who does a lot of personalised care planning sat down with an individual who's type 2 diabetic, went through a personalised care plan, set them goals, put them in a group. But they were talking through their circumstances and actually what the individual learned when they went through this process. Why is it that I fall into a situation where my diet's really bad? Why is it that I'm not getting support, that I need a home? And when he worked through it, actually his relationship at home had broken down on so many levels, like in terms of his wife, there's issues with his grown-up children, he had let it, he didn't get that support. So I think some of this just journey is actually very personal to the individual, and it's very difficult to get to the root of the problem. So that's why I put my hands up and say digital doesn't always work, actually, because you can throw all sorts of technology at people, and perhaps if they don't engage with it properly and really consume it in the way that it helps them, it's not going to have that huge impact. So like when I started this, it was very difficult to get out into the marketplace, talk about apps and everything else, but NHS England have done some really good work over the past year in that they've created a library of trusted applications, so we're on that library. And it's taken a lot of work to sort of go through the governance and everything else, but trust is another big thing, right? So the key thing is that having something that you can trust, and the content behind it that you can trust, and the individuals that are going to support you, right, to that you can trust as well. One of the things that I'm quite excited about this year was that when we engage with different groups, localization was key, right? So what we found was that, if we can perhaps work with GP practices and understand what the local resources are around that GP practice, like there's libraries, swimming pools or whatever it is, and then get those businesses engaged around that patient, and then reward them in their locality, that has much larger levels of efficacy in terms of the engagement and stickiness to the individual, because it's localised and it's personalised in terms of what they want to do. So I'm going to quickly finish. Yeah. So I also wanted to share what we've learned at the social prescribing side of things. So we've been asked by the GP practice to work with them in the social prescribing side of things, and these are the capabilities that have come out that are quite key. I'll just pick out a few. So it's the initial questionnaire about the patient activation measures to understand, well, where are they? How do you baseline the individual so you can measure progress? The directory of services, and it's the self-management side of things, self-service side of things in terms of appointments, getting access to local resources, understand what they are, getting access to national resources, getting local business involved, getting remote support, and the feedback in terms of what they're trying to do. And while we're talking about capabilities, I won't go into this, but there's a whole range of asks from the patient advocacy groups and the clinicians that we work on. They don't want to see reams and reams of data. They want to see data that's impactful for them within a few minutes, so they can identify what the issues are and correlate clinical stuff, which is self-management, but also qualitative information about how they feel, and bringing those two elements together quite softly. And it all has to be underpinned by really tight integration. So our work with Sollis, right, is based around integrating very tightly, so we get that information, but also we can send the information back, but integrating to the other things that are relevant to that individual in terms of wearables, the health record, and all that kind of good stuff. I hope that's been quite useful.
For more information and insights, visit our website, sollis.co.uk.